wanted to get through a few details. So the slides will be available for everyone after the webinar. For those of you who checked out our website recently, you will see that we did have a presentation uploaded. It is an older version, so we will replace that one with the version you will see today, and you will receive an email following this webinar with the link to where you can download that presentation. Also, if you are calling in today through the phone line, at the end of the presentation, we will open up the lines so that you can ask questions, and you can press *6 to ask a question if you're calling through the phone line. If you're using the computer microphone, then please use the chat option on the control panel that pulls up on your right to ask any questions you may have. If you have any trouble with the phone line itself and unmuting yourself, please just use the chat line. We will have somebody monitoring that box to answer your questions, and we will repeat those and have those answered for you. Okay. So before I introduce our speaker, I want to launch a quick poll. I would like to ask everyone to please let us know how many people are listening to this webinar on a phone line. If it's just you, then please mark 1. If it's more than 1, then please let us know. That helps us know how many people are actually listening to the webinar. And I will repeat this poll at the end for those who logged in later to provide that opportunity for us to get a better feel on how many people were in this webinar. Okay, we'll just give it a few more seconds. Okay, thank you so much, everyone. That gives us a really great idea. All right, so now to get us started, our speaker today is Victoria Lombardo. Victoria Lombardo is the Associate State Director of Program Services for the March of Dimes. She's responsible for overseeing the Community Grant and Award Program. She also has more than 25 years of experience as a maternal child health director, and she holds a Bachelor's of Science in Nursing from University of Pittsburgh and a Master's of Science in Nursing from the statewide nursing program at California State Dominguez Hills. So I will pass over the rights to Vicki and let her get going. Vicki, take it away.
I'm taking. Hello, everyone. Let me show the clean version of my screen and bring up the first PowerPoint. And you actually have most of the slides that were posted earlier. So if you have those in front of you, you may just see a change in order. We really didn't add that many slides. There are 2 that we did add, and so I will let you know. So you all play an extremely important part in our efforts to reduce preterm birth in the United States, and that's what I'm talking about today. So what I'm going to be going over is the impact of preterm birth. Sometimes we get very comfortable with preemie babies because we do a good job of taking care of them, but we aren't challenging ourselves necessarily for preventing preterm birth the way we should. So I'm going to be talking about that. We'll talk about what the March of Dimes is doing about it. 3 things the women that you work with can actually do something to reduce their personal risk. I want to talk about, just review with you the signs and symptoms of preterm labor and how to teach them and how important that is. And then we're going to discuss the risks of early elective deliveries before 39 weeks gestation and why that's a bad idea, even if the doctor's going to be out of town and all the other reasons they will give you. Last but not least, I want you to be able to identify at least 4 resources, free resources, that you can use to enhance your classes as you teach women about the importance of having a full-term baby. So first I'm going to talk about preterm births, and the definition is Any baby that's born before the completion of 37 weeks of pregnancy is considered preterm. We don't get really uncomfortable with those 36-weekers, but they're really preterm babies, and so we need to pay attention. The premature birth is the leading cause of death in newborns and a major cause of childhood disabilities. So it's not just a little problem, it's really a big problem, and it's an expensive problem. 2 years ago, 2 years ago, because it was in November, ACOG came out with the new definitions of the term of pregnancy, how long a pregnancy should be. Up until this one, we were all saying that, by 40 weeks, we need to deliver the woman. So they've broken it up a little more. We've known from the babies that late preterm, in that blue area, that late preterm birth those babies are special. They look like they're term, but they're not acting like they're term, and we need to do a little more observation of them. Then into that term category, from 37 to 42 weeks, those babies, if they go into spontaneous labor anytime in there, those babies will do well. But that purple section where it says early term, that's where we get into trouble when we start doing inductions and elective C-sections before the mom goes into actual labor. And I'm going to show you some information as to why we shouldn't be doing that. Full term actually goes from 39 to 41 weeks. What we need to remind ourselves is the fact that due dates are estimated dates of delivery. They're estimated, and that estimated word is very important in there. So nobody can tell you exactly the day you're going to deliver, except for those repeat C-sections. But we need to make sure that they're in the right window and they're beyond 39 weeks gestation. Pregnancies do go past 42 weeks, and sometimes those moms, they just don't go into labor spontaneously. By the time they get to 42 weeks, they're considered post-term, and it is recommended that they deliver at that time because the placenta begins to age, and it doesn't work as well. The babies stop growing, and some of the babies get into trouble. So we don't want that to happen. So in that red area, we do want to electively induce labor and get things going. Some of the causes of preterm labor, well, first of all, we know a lot of the causes. We only know about 50% of them. So often we don't know why. A mom, you see her, she is compliant, she does everything you ask her to do, and she ends up with a preterm baby. And that's what the March of Dimes is looking for, those answers. The risk factors, however, we do know several of the risk factors. Some of them are listed here. One is smoking. One is being obese or overweight. We also know that age makes a difference. We know that blood pressure makes a difference. So some of those chronic health conditions can help us predict whether a mom is at risk or not. And I have a more comprehensive slide a little later in the presentation. This is where the March of Dimes is looking for the answers. We have launched multi-million-dollar research centers across the country, and they're looking for that other 50% of the reasons. The first one was launched at Stanford University School of Medicine. So they're named the March of Dimes Prematurity Research Centers at, and in this case, the Stanford University School of Medicine. They're looking at identifying fetal genes that dictate preterm birth. So what is it about the fetus that is causing preterm birth to happen? In the Ohio Collaborative, there are several organizations as a part of that, several major medical centers and universities as a part of that collaborative, and they're looking at new genes that govern pregnancy. That's from the mom's side. So what is it about the mom that can help us predict when there's a risk? In St. Louis, in Missouri, the Washington University Center is looking at imaging methods. We're looking at early cervical changes. Can we work with those moms that have short cervix, and can we help them have term pregnancy by changing what we're doing and getting them diagnosed earlier? In Pennsylvania, they're looking to they're looking at the cervical changes and the vaginal microbiome. We're discovering that the germs that live inside your body make a big difference, and they change. And actually, a paper has been published that talks about preemie moms versus moms that have term babies. the microbiome, the preemie mom's microbiome changes the closer she gets to that preterm birth. We don't know why that happens, but we've made that observation, and it begins answering some of those questions. Last but not least, in Illinois and Northwestern, Duke University in Chicago, they're looking at mother and fetal cell interaction, and how does the baby communicate with the mom that I am ready to deliver, or how does he or she miscommunicate with the mom? Fun stuff coming out of there. So this is a premature baby. A lot of you haven't been into an NICU. This is a pretty healthy premature baby. But you can see that the baby is still receiving oxygen, and that other tube that's taped across his cheek is actually a feeding tube, because this baby is not old enough to suck, breathe, and swallow in an organized manner, nor is he able to have enough energy to get a full feeding down. So now I've described premature births to you, and I'm going to give you some data, but I have a quiz for you. So I need to give the control back to Fernanda. Uh-oh, I don't have that capability anymore, Fernanda.
I got it, Vicki.
Okay.
Okay, everyone, if
we're
you
going to ask.
Go ahead, Vicki.
Go ahead. If tell me what you think, where the United States ranks, high, medium, or low in our rate of preterm births. Are they voting, Fernanda?
We're at 88%, so keep voting, people. 91. I think we're good, Vicki. I'm going to go ahead and close it.
Okay, can you give I can't see the results.
Yes, I am sharing them now.
Okay.
Can you see them now, Vicki?
I can't, because I'm sharing my screen.
Okay, so let me share my screen here. Hold on.
There we go. Oh, a lot of you know the answer, but some of you don't. Okay. So 62% of you think that our premature birth rate compares as a high level compared to other countries in the world. 33% of you say medium, and 4% of you say, oh, we're the lowest. So let me show you what is actually going on here. This is where we rank. We actually rank in the middle. It's something that I'm certainly not satisfied with. The countries in red are those that have the highest preterm birth rate, and luckily we are not part of those. But we do rank not with the European countries, not with South America, not with Canada, not with Russia, not with China. We rank with,
Vicki, I'm sorry. I think you need to share your screen back with everyone. I'm not sure if everybody can see the screen. Can you look up on top? I'm sorry.
Okay, yep, show my screen. There we go. That probably helps, huh?
There we go.
It came back after you shut yours down. Let me just do the right sharing. Is it in clean? There we go.
Yep, we can see it. So we're good. Thanks, Vicki.
Okay, so you can see my map that I was referring to. I want to be in the United States on a par with these green countries that have the very lowest preterm birth rate. And you know, some of those countries actually have preterm birth rates in the 5% range. So the United States has some work to do. When we look internationally, okay, move. My slides are not progressing. Let me see. I think, there we go. When we look internationally, we see that globally, we're talking about 15 million babies are born prematurely. 8 million of those have serious birth defects and so forth. That is a big problem with these little babies. Down at the bottom of the screen, we can see that 15 countries in the world account for 2/3 of the world's premature births. The sad part is, look who made the list at number 6. So the United States, we need to take this very seriously, and we have begun to take it seriously. Here in the United States, about 4 million babies are born nowadays. About 5 years ago, or 10 years ago, it was about 5 million, but we've decreased that. Now we're down to, it used to be 500,000 babies, now 380,000 babies are born too soon. So that's still too high a number, and we want to do something about it. And over 23,000 don't live to see their first birthday. So the March of Dimes is doing something about this. In 2003, we launched a prematurity campaign, and we wanted to decrease the rate of preterm birth to 9.6%. And there were a lot of doubters out there that said, you can't do that, you can't do that. Well, indeed, we did do that in this last year, in 2015 data year, which is when we have the birth results. We did hit 9.6%. So the March of Dimes leaped into action, and we changed what our goals are. So by 2020, now we want to get lower than 9.6%. We believe we can reach 8.1%. And by 2030, we can get down to 5.5%. We don't have all the answers to reach that 5.5% yet, but we're counting on our research centers to give us a little more information so that we can hit that mark by 2030. In the meantime, we still want the general public to understand that prematurity is a problem. You don't want to voluntarily have a preemie baby. They're not just little-term babies. They really do have problems, and we don't want it to happen. We want this to impact the world, the globe. We want all countries participating, and then indeed, increasing numbers of countries are addressing the issue of preterm birth. We want to focus our research and interventions, and I told you about our 5 research centers, and we want to always expand the quality of healthcare services to moms, making sure the practitioners are using the latest best practices as we care for moms. This is what the preterm birth rate has looked like in the United States. You can see that this goes from 1981 through the present time. Those hash marks down at the bottom there between the years just show that there are not consistent spaces between the years, but just trust me, from the early 1980s until 2006, the preterm birth rate consistently went up in the United States. Now, I told you in 2003, the March of Dimes launched the campaign, and we didn't start seeing results until 2007. But since that preterm birth rate has continued to go down. Now, the reason why the year for 2014 it shows 9.6%, the reason it's blue is because the National Center for Health Statistics changed how we establish a due date on the patients. All those green lines were based the due date on last menstrual period. And let's be frank, ladies, we know that every woman doesn't remember the exact first day of her last menstrual period. When they give it to you, that's probably an estimate. Unless they're having infertility problems, they're really not logging it. They just know it happened around 2 weeks ago. But yet, when we start talking about preterm birth, we talk in terms of fractions of weeks. They are 32 and 5/7 weeks. Well, that's kind of tough to do when they gave you an estimate in the first place. So we found that wasn't real accurate. So what the obstetrical estimate is it takes the information from the last menstrual period, it adds in the findings from the early ultrasound done before 20 weeks, and it takes into account any infertility work that has been done and what those doctors say the timing of the pregnancy was, and using all of those indicators, then determine the estimated date of delivery. Based on that, the preterm birth rate in the United States has gone down now to 9.6%. And you can see the 2 goals there, so we still have to get into the purple. So we also know that progress is not being shared equally. The United States is going down, but there are groups and areas geographically where preterm birth is still a big problem, much bigger than in some of the other areas. And the March of Dimes is actually looking in these coming years to really focus on those high-rate areas, because preterm birth is still the #1 killer of babies, and that's sad. So premature birth report cards is one of the ways that we hold states to task, and we say, okay, we're releasing your report card because we're very competitive people and we want to get A's on our report cards. So we enhanced the report card this year. You have a grade, but now we're also looking at specific cities or counties within the state and comparing them. We're also giving each state some comparison on race and ethnicity. So let me show you what that means. This is what the United States looks like. And when we say our goal is to get down to 8.1%, look, we've got 4 states already there or below it. Oregon's at 7.7%, so that means the rest of us can do the same thing. California is at 8.3. We got a B because they changed. We had an A the year before because we hit the 9.6%, but now the new goal is we're compared to 8.1%. And you can see that some states are doing a great job, other states not so well, and then when we go to the south, that's where our highest preterm birth rates are. So we want to concentrate efforts in those areas to actually help them bring down that preterm birth rate. We're not going to ignore California, but we're really going to roll up our sleeves and look at those southern states. This is what the report card looks like. Here's California's, and yeah, we got the B. Next year we'll have an A. That's everything. I have to do that. So the top part is the letter grade, and then I've got blow-ups of the next section. So in the cities in California, this is how our cities map out. So there's Los Angeles, one of our big cities. We're at 9.3%. We're above what California has achieved. So what's going on in Los Angeles? And when we compare Los Angeles to Oakland, for instance, Oakland is an 8.2%. So what do they have going on there that's so good, and why can't Los Angeles get there? So that's what we want the cities to do. We want them to compare them with one another. We want Fresno and Stockton that have the highest preterm birth rates to reach out to some of the other cities and see how they are different and see if they can copy and implement ideas that are working in some of our other areas. The other part that we did is we gave every state a disparities index. Now this index is not based in any way on the number of babies born to each race or ethnicity. It's purely this grouping and what their percent of preterm birth is. So for our African American moms in California, that preterm birth rate is 11.8%. For our Native Americans, 9.2%, and so forth, down to our white moms, and it's 7.9%. So statistically, we looked at the difference between what our white mom preterm birth rate is compared to our African American mom, and indeed that put us with a disparity index of 19. So it's the difference between those two rates. Because if you can do it for one race, why can't you do it for another one? And that's what we're challenging people to question themselves about. So in California, we're the most populous state in the nation. We're very diverse. 1 out of every 8 babies in the country are born in the United States. So 1 out of every 28 babies are born in Los Angeles County. So when we make changes, the work that we do here really does impact the country. But you can see what percentage of preterm births or what percentage of live births are in each of these ethnic groups. This is what California looks like. We rolled up our sleeves and began working, and in 2007 we began bringing our preterm birth rate down, and now this shows we are now down to 8.3%. So we should be proud of that. And other states are looking at us to see, what are you guys doing? How do you get it? How are you doing so well? And how can we do the same thing? What programs can we implement so that we can start looking like you? California still has some work to do, though. When we break down California by county, you can see the darker the blue the county, the higher the preterm birth rate. So depending on where you all are living and working, you can see whether you have a low preterm birth rate or you still have some work to do. Our Central Valley counties are we're working hard up there to see what is going on among our rural moms. Is there something different about them than what we are achieving in our coastal moms? Because you've got, when you look at Ventura County and Monterey County, it's highly agricultural, but those counties have low preterm birth rates. So why does the Central Valley have higher? Those are the kinds of questions we're looking for the answers to. So in California, what we're looking at, we have been able to drop our rate by implementing, we've worked with 80%, at least 80%, 87% of our hospitals have implemented the elimination of elective deliveries before 39 weeks gestation. That has made a huge difference. Preterm Labor Assessment Toolkit is something that we work with hospitals, and again, this is the quality of care. This is a standardized methodology for evaluating moms when they come into the hospital with contractions before 37 weeks, because sometimes they're in labor and sometimes they're not, and I'm going to talk a little bit more about that later. We also have a whole initiative working with how to get moms as healthy as possible before they get pregnant or between their pregnancies. So that's by going to Every Woman California. I don't have a link to that in this slide set, but that's where we're working on programs helping moms be healthy before they get pregnant and between pregnancies. And then last but not least, you all, or many of you, are very familiar with Becoming a Mom, Comenzando Bien. We're active in, we know, 56 sites in the state. We know that there are more across the country. We're reaching over 18,000 women, and what we've found in these, by teaching these classes, is the women are hungry for information, and women will make heroic changes in order to have a healthy baby. So the rest of my presentation is going to talk about what women can do. That's going to come last. First, I'm going to talk about what you can do and what your role is in this prematurity problem. Are there any questions up to this point? Has anybody texted in any questions?
No, Vicki, but we are typing into the chat box the link to Every Woman California, by the way.
Okay, thank you. So feel free, as you have a question, to send it into the chat box. Like I said, we'll talk at the end of the presentation, but opening and closing phone lines can sometimes cause confusion. So I'm going to go into preterm labor. You all have had patients that have gone into preterm labor, so what's going on there? So the definition of preterm labor, first of all, is a little muddy in some of our hospitals, and so we're working with that. ACOG clarified that for us in 2012. And preterm labor occurs when contractions are happening between 20 and 36 and 6/7 weeks of pregnancy, and it's whether they have ruptured membranes or not, but they must have cervical dilation of at least 2 centimeters or cervical change as a result of those contractions. Many of our moms that have been diagnosed with preterm labor actually don't have preterm labor. It's actually those contractions are like the uterus doing push-ups, getting ready for labor to begin, but it's not really labor. So teaching the hospitals how to organize their assessment and thinking in assessing these moms will help us not intervene when we shouldn't be. Because in actuality, 50 to 70% of these moms go on to deliver at term if we just don't do anything. These are the risk factors. This is that slide I referred to at the beginning. So it's not just smoking, but it's all these things begin adding up. And the more things an individual mom has, the higher her risk of actually having a preterm baby. The most telling risk, though, for a mom with a second pregnancy is that first bullet up there. If she had a baby, a preterm baby the first time, she's at much higher risk of doing it again. So those moms we really need to pay attention to. So taking that careful prenatal history is important, particularly if she wasn't seeking care at your site when she had their first baby. Then there are things that we can do. Now there are things that don't work. ACOG has come out and actually said it. And the 3 things that we've consistently been doing for these moms that have early contractions, we put them on bed rest, we tell them to hydrate, and we put them on pelvic rest. Pelvic rest just frustrates mom and dad. Water is fine. Hydration is good because many people don't drink enough water. But bed rest can be dangerous. Bed rest actually can lead to loss of muscle mass and loss of bone mass. It can cause clots in the veins, and it can get a mom into trouble. So we shouldn't be putting her on bed rest just willy-nilly. We have to be careful and weigh the risks against the benefits. And there's no evidence in science that proves that those 3 activities make any difference. But on this slide, these are the things that do make a difference. If a mom had a preterm baby the first time, if we give her progesterone throughout her pregnancy the second time, we'll reduce her risk of having another preterm baby by 70%, 70-75%. We can also, if her cervix is beginning to shorten later in pregnancy, we can give her progesterone suppositories or gel, and that will help that cervix maintain so that she has a better chance of going to term. If we catch it early, we can also put a stitch around that cervix to help it stay closed. So those are all things that we can do early throughout her pregnancy. Once we diagnose that she truly is in preterm labor, there are 3 things that we can do. We can give her antenatal corticosteroids. Now that's a big word, but that's an injection that we give to mom that helps the baby's lungs mature so the baby does significantly better after the baby delivers. We can give the mom medication so that we can slow down her labor to do 2 things. One is to get the corticosteroids on board because they are given over a 24-hour period. And we can also slow down her labor to make sure that she's at the right facility. Does this hospital have an NICU, and is it equipped to take care of this gestational age baby? So if she's at 34 weeks, maybe you're perfectly okay, but if she's at 26 weeks, maybe that baby shouldn't deliver at your hospital. You need to prepare her and send her to another hospital. So doing those things all ensure improved outcomes for that mother and the baby. So we want to give ourselves time to do that. This is the difference that 17P, which is 17-alpha-hydroxyprogesterone caprate, say that 22 times, that medication that's given to moms weekly throughout their pregnancy. This is the reduction in preterm births, both by gestational age, that's how much we've been able to reduce their risk of preterm birth, but also in our African American moms, and those are non-African American moms, so it's something that's good for everyone. This is the difference that those antenatal corticosteroids make. Reduce babies' risks of all these complications by up to 50%, reducing neonatal death by 30%. Getting those on board are really important. And hospitals are missing 33% of those opportunities. So we're working with them to help them get this important medication on board at the right time. So here's what we're doing about it. This is the Preterm Labor Assessment Toolkit, and we're implementing this in different hospitals. And it gives them a recipe, an algorithm to follow, and what to do. So we're working with the hospitals and the doctors to teach them this information. It breaks down to isn't she having cervical change? So if she's having no cervical change, we should send her home and educate her. If she is having cervical change, then we need to get those medications on board and look to see if she should be transported. So where do you come in on all this? Because that's in the hospital. So you need to teach your patients what are the signs and symptoms of preterm labor, and that can be confusing. I have a slide that goes through them, and we'll go through them and explain why that can be confusing. You can help support your doctor, remind your doctor for the hospitals to standardize preterm labor assessment. And if some of you are actually childbirth educators joining this webinar, you can work with the hospitals to help them standardize how they're assessing these women when they come in. All of you can empower women to talk to their healthcare provider. Give them a full history. Some of the things in women's histories are embarrassing, but if the doctor knows these things, they can help them be proactive in preventing their risk and lowering their risk of having a baby born preterm. You can also start in that 3rd trimester talking about spacing for the next pregnancy, the importance of that 6-week visit so that birth control methods can be talked about and the mom can give herself time for her body to recover from this pregnancy before getting pregnant again. So what we have done is taken these talking points and we've put them in patient language for you. So these are the things that a woman can do. Know the signs of preterm labor, so contractions, and this is put in women language. Your belly tightens like a fist every 10 minutes or more often. There's a change in your vaginal discharge. You're leaking fluid. You feel like you're passing urine, or you're bleeding from your vagina. You need to tell somebody. You have pelvic pressure. It feels like your baby's pushing down on you. Something changed. You need to tell somebody. You have low dull backache. Well, with pregnancy, you have a backache, but this is a different backache, and it comes and goes. That might be contractions. You're having cramps that feel like your period, and every woman feels cramps differently. some in the front of their thighs, some in their back, some are higher up. So explain to them that if you feel like you're having your period, you may be having preterm labor. And then if you have belly cramps, like you ate something wrong, and they feel it's in intestinal tract cramps, but they're not having diarrhea, it might be preterm labor. So helping them understand that if they've never done this before, they don't know what labor feels like, let them know all of these things so that they can do something about it. What are they supposed to do? They're supposed to call you. Or if your physician prefers, they should go to the hospital to be examined. So if they have any one of those signs and they think they may be in labor, they need to let you know or let your doctor know or go to the hospital. The doctor, and then we need to prep them and say, well, the doctor may tell you to stop what you're doing, lie down and rest on your left side for an hour, drink 2 or 3 glasses of water or juice, not soda or coffee, and see if they go away, because sometimes the women are just doing too much. But if they don't go away or if those symptoms get worse, they need to call again or go to the hospital. So we need to be careful. Women many times are reticent or they're afraid to bother the doctor or to bother the hospital. Remind them that the hospital is open 24/7. The doctor is there for them. This is their job. It's much easier to know that they're having these symptoms than to find out, oh, they've been having them for 3 days and now they're in trouble and it's too late to do anything. So they need to know that if they tell the doctor and communicate that there are things that we can do to help you. So why is it important? There are medications. This is in, I've taught you this already, this is in patient language. There are medications we can give you to help slow down your labor. There are medications we give you to help your baby have a better outcome. You might need to go to a different hospital if it's very early in your pregnancy. We need to get you to where the team is to take care of your baby the best way we know how. Getting help quickly is the best thing you can do so that the treatments can be started as soon as possible and your provider will not be bothered. We don't care how many times you come and see us, how many times you call us. We want to know. The March of Dimes has some tools to help you. There's the signs and symptoms of preterm labor. So what I just went over with you is written on this brochure. And the picture of the mom on the left-hand side, actually, we have a picture of a Latino mom, a Caucasian mom, or an African-American mom. So we have them to talk to everybody. We have them done in English and in Spanish. And in some cases, we have the words on little cards that are done in other languages also. But those are only available electronically. The middle piece there is actually a preterm labor booklet. It explains a little bit further. And then last but not least is a brain card. So when moms are worried about why do I have to do this so soon, teaching them why their baby, why we want to do everything we can not to have your baby deliver too soon, because your baby's brain is still developing. It needs every single week it can get so that your baby is as healthy as possible. Okay, whoops. And then on our website, and across the top there in small language, if there's a group of you watching, you might not be able to see it, but when you download the slides, you can see it takes you from the March of Dimes home site to a drop-down menu where you would look at complications and loss, and then you go on down to preterm labor and preterm birth, and that's where you find this information. That picture is actually a video that the woman can watch, and we have more information about preterm birth and resources and what they should be looking for. So there's a lot of information on our website for these moms, and we want them to become comfortable with it. And our website is in English and in Spanish, so encourage your Spanish-speaking moms to access that resource. Any questions about preterm labor?
We do have a few questions. Do you want to answer those now, or it's probably a good idea because we have. Okay.
While we remember.
Yes. So the first question was, for a woman having multiples, what is the time frame for her to give birth? What are some of the risks associated with early delivery of multiples?
Okay, we want the woman with multiples to go as far toward her due date as possible, but as far as the weeks gestation are concerned, about 50 to 75% of the moms expecting twins can deliver at term. When you get into the higher order multiples, then usually it is a volume problem and she's going to go into labor. So we don't want to electively deliver anyone, but she's probably going to go into labor and need to be delivered. The other thing that the doctors will do is they send them in for testing, and what that does is it looks at the baby and the baby's activities, the fetal activities, to make sure that that heart rate remains consistent. They look at the baby to make sure the babies are still gaining weight. And if the babies have good tone, they're moving around in the uterus, and it looks like they continue to gain weight and they're responding well to movement, then it's best for them to stay in there. So there's no set time. Each mom is a little bit different, but there is a different testing process that you can teach your patients why this is important. We want to try to get you as close to term as possible. So we know that you're at a higher risk of having a preterm baby, but as long as your babies look good, we want to get your babies as close as possible to term.
Okay. And there's a follow-up to that question, Vicki.
Sure.
Is from the same person. Is antenatal corticosteroids good for a mom that is having multiple births, i.e. triplets?
Yes, we give the medication to the mom. It gets to the babies through the placenta, so it would go to all of those babies, and it depends on their gestational ages. And yes, that is something that the doctors would do. Now, the only ones that we don't get, that it doesn't work for, are the ones where they come in, they're completely dilated, the baby's already starting to crown. We don't have time. We need 24 hours for that drug to work.
And then there was a question about the slides, and just to reiterate, the slides will be available after the webinar. We will send a follow-up email with the link where you can download the slides. And the slides are available for everyone to download for free. There was a question about downloading some items for free, but we're still checking if it was in regards to materials or the PowerPoint slides. So you can keep going, Vicki.
Okay. And our PowerPoint slides are presented in PDF. We put them up on the website in PDF. If someone wants a particular slide individually because you're going to be teaching something, just contact Fernanda directly, and we can send those to you. Some of the slides I'm using are copywritten, and you cannot change them. Some of the others you can. So we want to make sure that if the March of Dimes logo is on there, that they're not changed in any way, because we need to be careful of our message. So hopefully that makes sense to everybody. So the next one is what we do electively, and elective is an extremely important word in this. Early deliveries are indicated at times. There are medical reasons why we should deliver a mom early. It may be that she's getting in trouble or the baby's getting in trouble. It can be for either of those. And those higher order multiples that we just talked about is one of those situations where it's best for the babies and the mom to go ahead and deliver them earlier, but we want the babies to be in the best condition possible. But when we get into elective deliveries, and that's when we do it for our convenience or mom's convenience, that's when we get into trouble. And this slide shows how we get into trouble. These babies don't do as well as the term babies. Some of them do. I'm not going to blow smoke at you. Yes, a high percentage of them do okay. But do you want to cause a baby to end up on a ventilator? Do you want to cause a baby to go into the NICU just because you're tired of being pregnant? No, we want to do the best for our babies, and we want to help our doctors make the best decisions along those lines also. So this is the card. This is that brain development piece, and this tells the story the best. Any mom that sees this and thinks that it's okay to deliver at 35 weeks changes her mind as soon as she sees this. This has been extremely effective, and this was actually a card designed by moms in Kentucky when we were trying to decrease the number of elective deliveries done too early in a project we were doing there several years ago. And this card is now available across the country. If you come to any of our trainings, we give it to you for free, or you can purchase them from the March of Dimes. They're handy. These are not to be given out to the mom. We have one for the moms, and I'll show you which one, but the cards are for you to teach her. The baby's brain is making huge changes, and that brain development in utero is the best place. This slide we teach to doctors, so we've got all the big words on there, but just know the baby's ability to organize thoughts, to put random concepts together, to make good decisions, to control activities, that all is driven by the development of the brain, and we want that brain to be as developed as possible. I tease, I said, which baby do you want to have choose your nursing home later on? So yeah, I want the one on the right. So inductions, many of you weren't even alive in 1979. I know that. I've been teaching this a long time. ACOG came out and cautioned against elective inductions before 39 weeks, but we didn't listen. And we see story after story and data after data of elective deliveries happening before 39 weeks. So the March of Dimes is doing something about this. And even if you do fetal lung maturity testing, it doesn't guarantee that that baby's going to do well if you electively deliver them. So we're working to stop that. We've been very successful here in California. We collaborated with California Maternal Quality Care Collaborative and the MCH branch from the State Department of Health Services in the March of Dimes, and we wrote this toolkit. It's available for a free download. Most of our hospitals already have it. We gave it to them, and we taught them how to use it, but it's on prematurityprevention.org. If you have a new physician that's saying, what, and they want to see the evidence is all right there. So this is what, if hospitals implement, and this is a study that we did in 5 states across the country, we recruited hospitals to implement the elimination of early elective deliveries before 39 weeks. And look, they went down from a 27.8% rate down to 4.8%, under 5%, and many hospitals are down at 0% elective deliveries before 39 weeks, and none of them had any increases in complications. So we're doing the right thing, and we're saving babies from that risk of ending up in the NICU. Your part is to help your doctors, those of you that work in the clinics and the doctor's offices, help remind the doctor of the importance of that early ultrasound before 20 weeks gestation. This is the most sensitive time when an ultrasound can help you determine what the gestational age is of the baby and predict the estimated date of delivery. So that 20-week ultrasound is a key component of the new obstetrical estimate for that due date. The ultrasounds done later, after 20 weeks, they're not as accurate, and don't let the doctors change. I've seen prenatal records come in where they cross off the due date, and with every ultrasound. After 20 weeks, you can't change the due date. You're not supposed to, because babies grow at different rates after that. So normally I open the line and I have everybody tell me all the reasons. I'm just going to give you the reasons I hear every single day of why a woman says, can't you just deliver me on Friday? My husband is going to be home for the weekend. My mom can only come next week. I haven't seen my feet in weeks. My back aches. I can't sleep all night. I have heartburn. Can't we just deliver now? And then it goes on. My great-grandmother's birthday, I want the baby to have my great-grandmother's birthday. I want the baby to have a certain zodiac sign. My baby can't be born when there's a full moon. All of those are not good reasons why a woman should deliver early and risk having her baby have complications. We asked women when they thought it was safe to deliver. And look at that. The majority of them, more than half of them, 60%, almost 70% of them said, 50, 60, yeah, 70% of them said between 36 and 38 weeks is perfectly okay. So how did they do that? It's because women think in terms of, my pregnancy is 9 months long, there are 4 weeks in a month, 4 times 9 is 36, my baby must be term. They forget those extra few days and how important they are. So my first request of you is to always don't talk to your moms in terms of months. Even if they ask, tell them a pregnancy is 40 weeks long and you are now 29 weeks. You have more weeks to go. So talk to them in terms of weeks, because that way we don't get into trouble. There's pressure on the obstetricians. We recognize that. The doctor wants to be there for their patient because this is business. They want the patient to be happy. They want to keep coming back, but that's called codependency, when they give in, when they know they shouldn't be. The doctor doesn't want to be downstairs doing a hysterectomy and have a patient completing on the perineum up in the labor and delivery area. That causes a conflict. So if they can just deliver them while they're on call that night, that would be nice. They don't want to be wakened as much in the middle of the night. Well, they should have thought of that before they went into OB. They want to finish a movie. They want to have dinner with their wife and actually get to dessert. None of those are good reasons. And then what's the harm? The doctors lose track of what happens to the babies in the hospital, because if a baby is born preterm on Friday, ends up in the NICU, the doctor's off for the weekend, doesn't get back to on-call and doesn't see that mom until 6 weeks, asks the mom, how's your baby? The mom says, fine. The doctor may never find out that that baby was in the NICU for a couple of days, had needed oxygen, or was on a ventilator actually for 24 hours. And besides, the NICU handles these issues just fine. I've heard neonatologists tell obstetricians, I'll make you look good, your baby will be fine. And indeed, our neonatologists do amazing work that we don't want. That's not a reason to deliver early. The doctors also think they're going to reduce bad pregnancy outcomes, and the data is showing that that doesn't work. So here's some of those quote-unquote medical indications. They'll say maternal intolerance to late pregnancy. Well, yeah, she has edema, she has backache, she has indigestion, she's not sleeping well. Basically, she's whining, and that's not a reason. Really focus these moms on this is your time to rest. This is when your body is saving up energy to actually deliver a healthy baby. All these priors, she has a history of rapid labors, prior labor complications, prior shoulder dystocia. None of those will tell you if it's going to happen this time or not. So we have to manage each labor individually. Suspected fetal macrosomia is a big one. If you suspect fetal macrosomia, because ultrasounds are plus and minus 2 pounds, so you can't really have an accurate estimation of fetal weight. The only way to diagnose fetal macrosomia is to give her a trial of labor. If the baby doesn't fit vaginally, it'll tell you, and then you do the C-section. You don't induce to prevent it in the future. The possible reduction of risk, possible eclampsia, possible macrosomia, and stillbirth, none of those risks decreased by doing elective deliveries early. So the data does not support any of those indications. So what can you do? Teach your patient to talk about their pregnancies in terms of weeks, not months. They can teach their mom and their grandmother 40 weeks. They can all count 1 to 40. That's what they need to do, not months. Educate your patients about the risks of delivery before 39 weeks. Your baby will tell you when your baby is ready to deliver. Don't you try to tell your baby for your convenience. And talk about the fact that the baby may end up in the NICU. The baby may not go home with you in your arms. That's devastating experience to a new mom. Encourage your patients to get that ultrasound. You can help your patients remind you, help your doctors remember to get that ultrasound to date that pregnancy before 20 weeks. Empower your patients to ask questions. So your doctor says to come in. I don't know how many patients I've seen come in on Friday morning and they, why are you here? I'm here to be induced. Why? My doctor said to come in. The patient didn't ask any questions as to why they're being induced. So get your patients to ask questions. And I've got a slide that shows you the questions to ask. And then you take the lead in promoting this best practice. This is the wording for your patients. Important organ growth, including lung, brain, and liver, are still developing in those last 5 weeks of pregnancy. Babies born at 39 weeks are less likely to have vision and hearing problems. Those are caused by the treatments we have to give babies when they get in trouble in the NICU. The babies need 39 weeks to gain the weight they need, to put on the fat they need to keep their bodies warm and maintain their temperature. The baby's brain needs to be 39 weeks so they can learn to suck, breathe, and swallow in an organized manner, and that they can stay awake and have the energy to get a full feed in. Labor and delivery is like when a baby learns to walk or crawl. We know that babies crawl around 6 months, but some babies crawl at 6 months. Some don't crawl till they're 7 or 8 months. It depends on the baby. So it is an estimated date of delivery. We have to emphasize that estimated. Recognize waiting can be hard. We understand that, but it helps the baby make important growth changes, and that resting is important. Remind the moms to rest. So your due date may or may not be exactly right. If it's an estimate, it could be plus or minus 2 weeks. 2 weeks early could get you in trouble. The other important piece to teach them about inductions is that they may not work, and you double your chances of having a C-section just by having an elective induction. So if there's no medical reason, why do you want to increase your risk of having major surgery? C-sections cause problems in future surgeries. The more C-sections you have, the more risk of the placenta attaching to that scar. If that happens, when that delivery happens and the placenta lets go, the mom will hemorrhage and have to have an emergency hysterectomy. That is one of the key problems identified in California's increasing maternal death rate. And that's one of the things we want to try to avoid. And C-sections are major surgery. It takes longer to, it's a major insult to the body. People think that, oh yeah, let's do this because we can predict it. It's not good for your body to have major surgery, and we want to avoid it if we possibly can. There's more and more information coming out showing that babies develop that human microbiome, the germs that help them digest food and things like that, much better if they have a vaginal delivery versus a C-section. So there's more to come on this. So what is early? What's the big deal? Early term. This is what you tell your patient. This is a slide. I've taught you this information. This is putting it in patient language. So I want to give us time for questions and answers at the end, so I'm not going to read this to you. Just know I've already taught it to you, but this is what you can tell your patients. The other important thing to remind them, though, is if spontaneous labor starts before 37 weeks, that's okay. Don't panic. The baby has signaled the mom that it's time for her to deliver, and the doctor won't do anything to stop labor after 37 weeks, and the baby will do well. These are the questions the mom should ask anytime a suggested treatment or something is made by the doctor. What's the benefit to me? What's the benefit to my baby? What are the risks to me, or what are the risks to my baby? She can go on and ask, how was my due date calculated? You can ask that, but those first 4 questions should live with her throughout her life for any medical decisions that she's making for herself or for her baby. This is the teaching tool. I showed you this is the brain card that you don't give to the patient, but this is what you can use to teach your patients. They're in English and in Spanish. These are the brochures. This is the flyer on the left-hand side that you can give to the mom. The middle is just the back side of the flyer, so the information is there. And there's actually a booklet for those that remain unconvinced. This is our website, Don't Rush Your Baby's Birth, and across, just right under where it says Our Cause, in the black it says Home, Pregnancy, and 39 Weeks is Best. This is where you can, that's how you can get to it on our website. Remember, the website is in English and Spanish. This is our national campaign. We do have these posters. We give them to you. If we have them available in our offices, let us know. If we don't have them, you can purchase them from our catalog. They're $1 a piece. Interpregnancy interval is important. That 18 months between pregnancies is really important. Your body, the data is showing that the body needs time to recover, and that 18 months is very important. So helping the moms make sure they understand how important that 6-week visit is. 33% of the pregnancies in the United States, that's a high percentage, are actually happening before that 18-month period. So we'll reduce our preterm birth rate. It's estimated by 37,000 births in 1 year if we just get all the women to wait 18 months. So giving the women permission, but also helping them understand why waiting and what their body is doing and why that's important is an important message that you can give them in the 3rd trimester, and hopefully when you've convinced them to come back for their 6-week visit, why it's so important to help them let their body recover, use birth control that works, and choose the one that's best for them. So this is what the women can do. This is just reducing their risks, and you can go down this list. I see I'm a minute past my time, so I'm going to let you read this. And then these are the two slides of what the women can do. I didn't get to that part. These are the resources. This is a whole list of free stuff. This is from the March of Dimes. This is more. We've got, follow us on Twitter. Follow us on a blog that comes out every single day. The moms can sign up for these. We do them in English and in Spanish. If your mom had a preterm baby, share your story, or the other one in Spanish. I can't say it and they'll make fun of me if I do. So that share your story is a community of NICU families. Sometimes when bad things happen, you just want to talk to somebody else that survived it, and that's where they can find somebody that did it. You, your doctor, as well as your patients can all email us your questions to ask us at marchadimes.org or preguntas@nazarsano.org, and we will answer. We have health masters prepared health educators, a huge library. We will help you find your answers. We have free apps on the iTunes App Store. You have an iPad, you can download that magazine, My 9 Months. It's in English and in Spanish. It has embedded videos. It's a great educational piece. You can also download Cinemama, and I have a website that shows that. This is your Healthy Pregnancy Resources. We're also on Facebook. Please like us on Facebook. And I have to stop and tell you, that is Natalia. That's Fernanda's little girl, so she's very proud of that, and she's a cutie. This is where Cinemama is. This is what the app looks like, and what you do is you take a picture of yourself sideways every week, and it turns it into a movie for you. So it's a great way to engage the moms in watching their babies grow and watching their pregnancies change. Outside people around the 39-week campaign, other organizations, and these two slides have other resources. So if you're tired of our posters, use these posters. These are all free. You can get them from these different organizations. And last but not least, there's a wealth of information from the March of Dimes on YouTube. Please let your patients know about that. Please use them, borrow them freely, but caution your patients that not all resources on the web are trusted. All of these resources that I just gave you are trusted resources. They're based in fact. We want you to have very successful classes. The moms are all happy. The moms want to learn. We want to help you teach the moms the very, very best information we can, because you do make a huge difference. You're the one the mom talks to, not the nurse, not the doctor. It's you. So you can make a huge difference. This is how you can get involved with the March of Dimes. If you want to learn more, please check this out. Learn about what we're doing, participate, and thank you for your patience. I know I went 4 minutes over. Thank you so very much. Okay, if anybody wants to hang around for questions, I'm available to answer them.
Thank you, Vicki. And we do have some questions, so I appreciate those who are still able to stay on the line. I am going to open up the line so people can unmute themselves, but let me just ask the questions that were submitted through chat first.
Muted.
Okay, so the first question is actually a follow-up on the multiples question, Vicki. So for the moms having multiples, for example, triplets, a mother was told that was having triplets was told by her doctor that delivery would happen at 35 weeks. Based on the brain development slide, will this impact her babies? Vicki, if you're trying to talk, you might have to press *6 to unmute yourself.
There we go. Yes. Okay. So with triplets, this presentation was primarily about singletons.
There we go. Sorry about that, Vicki.
Okay. With triplets, we're fairly certain that she will not make it to term. Every once in a while they will. And so to tell that mom to give her 35 weeks is a good number of weeks for triplets to make it that long. And so using averages, that's probably when her uterus is probably going to want to start contracting. So explaining to the moms that our goal is to get it to 35 weeks. Yes, babies' brains will continue to develop after they deliver, but when there is no reason, when there's just a singleton baby, then we want them to develop in utero. Those triplets will continue to develop after they are delivered. We know that, but they may end up in the NICU for that development to take place. So we're balancing the risk of the baby with the risk to the mom, and that's what the doctor is setting them up for. Next question.
Thank you, Vicki. And the next question is, why is the 20-week ultrasound? The next question is, why is the 20-week ultrasound so important?
Because or less than 20 weeks. Because that's when that is the most opportune time. The fetus, when you compare one to another, it's the most opportune time to gauge how far they've developed up to that point. Beyond that point, they begin developing at different rates. They put on weight differently. Just as all of us look different, the babies start differentiating themselves much more in those latter weeks of pregnancy than they do in the first 20 weeks. So there's more consistency in that early pregnancy, in those early weeks, than there is later on. Just as you know, some babies weigh 10 pounds when they're born, some babies weigh 6 pounds when they're born. All that difference happens after 20 weeks, and that's why doing the ultrasound later on isn't a good time to decide when the baby, what the gestational age is.
Thank you, Vicki. Now, there's a follow-up to that question. So it says, what happens when the patient is late to care and are not able to get the ultrasound prior to 20 weeks?
So what we caution the doctors to do, and sometimes the patients will come in and they enter care in the 36th week of pregnancy. No, we can't give her a firm due date, and those are the patients that we monitor to make sure if she and the baby are looking healthy, that's when you just have to wait and let contractions begin. The baby or the mom will tell us by either the baby will stop gaining weight or the mom will start contractions when that baby has to deliver. We just can't give her a firm due date. So we just have to be patient.
Okay, and that concludes the questions that were submitted through chat. So now if there's anyone else on the line that would like to ask a question and they are on the phone line, they can press *6 to unmute themselves and ask a question. Okay, so I think we've got, I think that is it. Thank you so much, everyone, for participating in today's webinar. Thank you, Vicki. You did a fantastic job covering that information. And if anybody has any questions, please feel free to email me after. You will, again, receive the slides. You'll receive an email through GoToWebinar with the link to the slides, and you will also have the webinar recording available for you, so you'll be able to have someone else listen to this entire presentation together with the audio, and that will also be included in the same link. So if there isn't anything else, then thank you so much, and we will conclude this webinar. Thank you, Vicki.
Thanks.
That's what it said.